You may know me from last week. I don't know if you all were here last week when I was talking about post-traumatic stress disorder. So today I'm going to be talking about anxiety spectrum disorders in the elderly. And feel free to ask questions if you have any, and I'll get started. Screen. All right, can everyone see my screen? Okay, I'm guessing that's a yes. All right.
No.
No? Okay, how about now?
No, still seeing you.
Okay, and let me try again. All right, so I'm gonna share the screen. Here. Okay, how about now?
Yep.
Perfect. Sorry about that, guys. Okay. Here we go. All right. Okay. All right, so my topic today is anxiety spectrum disorders in older adults. All right, so the objectives of the talk today are to understand the differences and similarities between anxiety disorders in the general population, so that's all ages, as compared to how anxiety disorders, manifest in older adults. Second objective is to understand the consequences of untreated anxiety in older adults. And number 3 is to understand various treatment options in late life anxiety disorders. All right, so let's talk about the prevalence of anxiety disorders. So anxiety disorders are the most prevalent type of mental illness in all age groups. So the lifetime prevalence of any type of anxiety disorder is about 29%. Anxiety disorders are also common in the elderly. So they have about a 10 to 20% prevalence in those over age 65 years old. So typically though, like what we see is that anxiety disorders usually start as in younger ages and then they just continue into older age. It's very rare that an anxiety disorder will start in someone over the age of 65. So it typically anxiety has already been present in 99% of individuals who have it at the age of 65 years or older. So that that's something to be aware of, because if you see a new onset anxiety disorder in someone who's over the age of 65, you're gonna wanna make sure that there isn't something else going on. Is that person maybe experiencing a medical condition that looks like an anxiety disorder, like, some cardiac condition, for example. On the other end of that, the other side of that coin, anxiety disorders in the elderly are often undiagnosed or underdiagnosed because people may not recognize their symptoms. They may think it is part of a medical condition. Also because the sort of physical symptoms of anxiety disorders in the elderly are more prominent than the emotional aspect, or they may complain more about the physical symptoms. So there's two sides of that coin. All right. It is pretty important to be able to diagnose an anxiety disorder in elderly patients because there are a lot of consequences of untreated anxiety disorders. If an anxiety disorder is untreated, it can exacerbate cognitive impairments in elderly patients. It can result in poor quality of life. It can cause disabilities, or it may make it so that they are not able to complete, instrumental activities of daily living, or, just general activities of daily living. It may increase pain levels. It may increase, poor physical health. And it may also result in higher utilization of medical resources like emergency rooms. So it is important to recognize it and treat if possible. All right, so the most common, I'm going to talk in this section about all the different kinds of anxiety disorders. So the most common type of anxiety disorders in all age groups is specific phobia. And this is an intense, irrational fear of a place, thing, or event that actually poses little or no threat. And common phobias in all like age groups are heights, fear of escalators, fears of tunnels, highway driving, closed in spaces, flying, and spiders. Those are the most common. The lifetime prevalence of specific phobia is 11%. As people age, there tends to be a decreasing prevalence of specific phobias, at least in the studies that we have. So in those who are age 70, the prevalence of specific phobia is about 10%. In those who are age 79, that prevalence decreases to 4%. And the types of phobias that older adults have tend to be a little bit different or somewhat different than younger patients. So in addition to the other ones that younger patients have, a very common one is the fear of falling, and that occurs in up to 50% of those in long-term care facilities and in 50% of those who have fallen in the last year. Another very common phobia is dental procedures in older adults. I'm going to talk a little bit more about the fear of falling because that is very common and it can cause long-term isolation, and it's also highly comorbid with depression. So I think we should talk about it a little bit more. So this is kind of the sort of the cycle of the fear of falling, so sort of a vicious cycle. So what happens is sometimes as people age, they may develop comorbidities, they may, that may cause some increased immobilization, they may have deconditioning, which causes muscle weakness, and that in combination with other factors can cause a fall, which may cause an injury. This injury then results in fear of falling and reduced activity, and the reduced activity causes increased immobilization and increased deconditioning and increased muscle weakness, which then makes it more likely that they'll fall again. So it's a pretty vicious cycle. So you'll want to sort of address it both at the deconditioning level and both at the fear anxiety level to break that cycle. The next most common type of anxiety disorder in all ages is social phobia. And this is an overwhelming anxiety and self-consciousness in everyday social situations. It tends to be, so the prevalence rate in all ages is 5% over a lifetime. This prevalence decreases over age as well, as people age as well. But in some groups of older adults, it actually can get exacerbated or worsen as people age because they may experience embarrassment due to memory problems, which causes them to withdraw and isolate. They may also have shame about their appearance due to aging or to illness, which can also exacerbate an already present social phobia. So that's something to be aware of in some groups of older adults. All right. The next most common type of anxiety disorder is generalized anxiety disorder. So this is a constant debilitating worry, usually about just routine events during the day. If you ask these patients what types of things do you worry about, they can name many things, and they'll often just say everything. And it is accompanied by physical symptoms like restlessness, muscle tension, also accompanied by poor concentration and disturbed sleep. In the elderly, it often, the anxiety will often be, just about everything, but also it'll be more focused on things like health and finances and disability. It does tend to first appear anywhere from young adulthood through the mid 50s, and only 3% of people will develop it after the age of 65. But it's actually one of those anxiety disorders that has a mean age of onset that is the highest of any other anxiety disorder. If you look at like other anxiety disorders, most of them have a very, very early mean age of onset. So this graph, for example, shows that, separation anxiety and simple phobia have a mean age of onset of around like 6 years old. And then the social phobias will have it like an onset in later childhood. OCD and agoraphobia will be sort of in the teens, PTSD and panic disorders, early adulthood, but generalized anxiety disorder has a mean age of onset that is later than all those other anxiety disorders. It's usually like somewhere in the mid 30s. So that is just sort of something interesting about this particular anxiety disorder. But again, it's also sort of pretty rare for it to develop as a new onset disorder in people over the age of 65. Generalized anxiety disorder tends to be chronic, and it's sort of like the symptoms fluctuate depending on the stressors in the person's life. All right, so some more facts about generalized anxiety disorder. It's thought to be about 32% heritable, with environmental factors playing a larger role than genetics. So like if someone has had a very unstable life or upbringing, that would probably have a larger role in its development than heredity. Women account for 75% of those who are affected. It has a 5 to 6% lifetime prevalence, and in those over the age of 65, that prevalence decreases to 4%. But it's possible that that prevalence decreases because it is underestimated in the elderly, or it might not be reported as much, or it might be confused with medical symptoms, or also like these community surveys where they try to figure out how prevalent generalized anxiety disorder is, only look at people living in the community. They don't look at elderly adults who are living in nursing homes or long-term care settings. So, there's a caveat to those prevalence statistics. Again, it can be difficult to diagnose in the elderly because, elderly patients will come in with physical symptoms as opposed to emotional, complaints. They will be talking about general weakness, tiredness, restlessness, difficulty concentrating. And, even though generalized anxiety disorder is sort of a chronic condition, it can definitely worsen or emerge with other serious medical conditions like heart disease and COPD. All right, now let's talk about another anxiety disorder, panic disorder. So panic disorder is when patients experience sudden attacks of terror, and that is accompanied with other physical symptoms like pounding heart, chest pain, sweatiness, weakness, faintness, dizziness, or nausea. And in addition to that, the patients will also have a persistent worry about having more panic attacks. These panic attacks can really occur at any time, even during sleep, at night. And usually the panic attacks will peak at about 10 minutes after they start. But there are some patients who will tell me the panic symptoms can last much longer than that. And older adults will often worry that they're having a heart attack or a stroke, and it can be hard to differentiate that between a heart attack or a stroke. Younger patients have that as well, but it's even more confusing in older adults. The prevalence in those ages those who have a older age, like over the age of 55, is about 1%, and the lifetime prevalence is about 4%. It is more common in those who are experiencing things like tachycardia, gastric ulcers, and other health-related quality of life issues. So that can also make it sort of harder to determine whether it's medical or psychological or psychiatric. Other things to ask about with patients who present with these symptoms, you really want to ask them about whether there's any use of stimulants, whether there's any use of substances, like drug withdrawal syndromes can definitely look like a panic attack or may contribute to panic attacks. So it's important to ask about those, even in older patients. Sometimes we think that that's not an issue with older patients, but substance use can definitely be an issue with older patients too. The next thing I want to talk about is obsessive compulsive disorder, even though it's no longer really considered a part of the anxiety spectrum disorders. So in DSM-4, it was considered an anxiety disorder, but in DSM-5, it isn't an anxiety disorder anymore. It's in a different category in the obsessive compulsive related disorders. But I think it's important to talk about nonetheless. So this is the OCD cycle. Typically, there'll be an obsession of some sort. So that an obsession is an unwanted, distressing thought, urge, or mental image. So common obsessions in elderly patients are that they might cause harm to a loved one, or violence to a loved one that they don't really want to do. And then as a result, these people will have anxiety, like some sort of, it'll cause them distress to have these thoughts. And they feel a need to do something to relieve that anxiety. So they start to perform compulsions or rituals that help make the anxiety go away. And some common compulsions are checking, touching things in a particular order, counting things, or making sure things are ordered or symmetrical. These compulsions will will cause some temporary relief from the anxiety, but usually the obsession will come back sooner once they've completed the compulsion rather than helping. It actually makes things worse. So, obsessive compulsive disorder typically starts at a pretty young age, usually childhood or as a teenager. It has a 1.5% past year prevalence in adults ages 18 to 29. And those over the age of 65, it has a past year prevalence of 0.5%. So it's not that common among older adults, but you do still see it at times. Another obsessive compulsive related disorder that sometimes comes to light in older patients is hoarding disorder. So typically the onset of hoarding disorder is usually also before age 20, just like OCD. And few have like an onset that's after age 40. But like sometimes it doesn't really come to light until people are older. And it used to be thought that maybe it's coming to light because, symptoms get worse as people get older, but the data and the literature don't show that to be true. What we think is actually occurring, like why it seems to come, more to light as people get older, is that the implications of hoarding worsen as people get older. So because they have so much junk lying around everywhere and they're also more frail, they're more likely to fall as a result of the hoarding. So then they might come to the office of a psychiatrist for that reason, or a family may bring them. They may also be more likely to have fires occur, like, if they forget that they're cooking and there's junk everywhere, it may cause a fire. Mold, poor hygiene and nutrition can be a result. Food contamination can result. Definitely isolation. The majority of older adults with hoarding disorder report never having friends or family visit their homes. So can be pretty devastating, and it's even more devastating for older patients. So the question is, what can cause or exacerbate an anxiety disorder in older age? So as we know, most people who have anxiety in older age have already had it when they're younger, but it can fluctuate, and as people get older, there may be, reasons why it can get worse in some people. So extreme stress or trauma can exacerbate an anxiety disorder, bereavement, the use of medications or drugs, whether they're prescription or over the counter. Other medical illnesses can worsen or exacerbate a anxiety disorder, like an MI or COPD. Neurodegenerative disorders like Alzheimer's disease definitely can exacerbate it. And then just sort of the general sort of stresses and changes that come along with aging can also exacerbate anxiety disorders. Like we talked about, the fear of falling, being unable to afford living expenses or medications, being victimized as one gets older, depending on other people, being alone, or the fear of death. Those are all things that can exacerbate anxiety. It's also important to realize that there's a big connection between anxiety disorders and other mental health problems. So up to 90% of patients who present to you with an anxiety disorder will also have another mental health problem. And the most common ones that they may also have are major depressive disorder, dysthymia, bipolar disorder, or a substance abuse disorder. So you definitely want to be checking for other mental health disorders in these patients. And if you're going to treat the anxiety sufficiently, you're going to also have to treat the other the other mental health disorders as well. All right. So this slide about the treatment of anxiety disorders in late life for anxiety, is basically identical to the one that I had last week for PTSD. So, one of the treatments for anxiety disorders is definitely medications or psychopharmacology, but you really have to keep in mind some special considerations for older patients. So there's limited data and efficacy on the safety of drugs in late life anxiety disorders. Older adults are not included in medication trials very much, and when they are, it's usually the healthiest patients that are included in those trials. So when we use medications on patients with anxiety disorders who are older, we really need to keep in mind the general pharmacotherapy recommendations that we always use for older patients. That you want to start low with the dose and you want to go slow. So half the dose you would normally start with, and you want to increase at half the rate you would normally go at in a younger patient. You want to check the patient's kidney and liver function. You want to make one change at a time. And when you are doing your medication teaching, you want to make sure that if that patient has a caregiver or someone who's very involved in their life, that that person is also involved in the teaching. So the first line drug choice in anxiety disorders, just like in PTSD and depression, is SSRIs or SNRIs. And that's true in older patients and in younger patients. So in geriatric depression, we know that SSRIs and SNRIs have a diminished response in older patients. Like older patients just don't respond as robustly as younger patients do. So we suspect that in anxiety disorders, this is probably true as well. When you are using an SSRI or an SNRI in older patients, you probably do not want to use paroxetine because of its anticholinergic side effects. You also want to be careful with fluoxetine because it has a long half-life and it has a lot of drug-drug interactions. So typically the first choice we will use is sertraline. And then for SNRIs, I'll usually use, I didn't write it in the slide, but I'll usually use like duloxetine rather than venlafaxine because venlafaxine has a pretty short half-life. So there's like a lot of the withdrawal symptoms with venlafaxine. And then there's also like more of the side effects that like blood pressure increases with venlafaxine. So I will usually go with duloxetine if I'm going to use this SNRI rather than venlafaxine. Other medications that can be useful. One of them is buspirone. This one medication has mixed results in treating anxiety in the studies that we have. One of its benefits is that it's less likely to cause side effects or interact with other medications. So it's one of the safer ones, but its efficacy is equivocal, I guess. Benzodiazepines were once the treatment of choice for anxiety in elderly patients. And you'll see that still a lot. Like there's a lot of older patients that come in on high doses of benzodiazepines because that was, it used to be the primary treatment. However, the risk to benefit ratio is not favorable. So again, as we know, benzodiazepines can cause or exacerbate memory impairment. They can cause unsteadiness and falls, and they can cause incontinence. So, if you can avoid using them, it's definitely better not to use it. However, I do have some older patients that I do use this medication in. So if they need a very rapid anti-anxiety response, I may use it, but I try to keep it short term because it's fast acting, unlike the SSRIs and SNRIs. All right, another treatment are beta blockers. So these medications can be effective for social phobia and performance anxiety. And they work because they prevent the physical symptoms that go along with anxiety disorders, like sweaty hands and like a beating heart that goes really fast. Some doctors refer to beta blockers as beta adrenoceptor antagonists because they actually block the effects of epinephrine or adrenaline on the beta receptors. I usually don't use this medication in older adults. because it's often like it crosses the blood-brain barrier and it's associated with depression, sedation, and fatigue. I'm talking specifically about propranolol. That's the one that's used most often. The other issue with it is that it has multiple interactions with other medications. So that's another reason that I don't use this as often in older patients. Mirtazapine is a medication that I use often in older patients. I use it more often in older patients than younger patients. Even though there are no published studies on its effectiveness in anxiety disorders, we know it is effective for depression and PTSD. It has a safe side effect profile in the elderly. It has minimal drug interactions, and it's tremendously helpful for patients with insomnia or reduced appetite. So it's a good one. Antipsychotics. So quetiapine is an antipsychotic that has been shown to be effective in generalized anxiety disorder in several clinical trials in adults of all ages. And it can be used as a monotherapy or it can be used as adjunctive therapy. And it's really the only one that I usually use for anxiety, the only antipsychotic, because evidence for other antipsychotics is not well characterized, it's not robust. Unfortunately, quetiapine should really not be used that much in the elderly because it's not that well studied. It also has multiple side effects, even younger patients and older patients, but more so in older patients. The side effects include metabolic effects, increased mortality rates in those who have cognitive impairments and dementia. It can cause osteopenia and bone loss. So it's definitely not, I wouldn't recommend it as a first line treatment for anxiety, but sometimes we use it as a second or third line treatment. Okay, now, because drugs are, have a lot of side effects and they aren't as effective in older adults, it's often not the best choice for older patients. Often older patients actually may benefit more from psychotherapy. And older patients may prefer that. They may prefer alternatives to drugs because they may say, I'm already on a lot of drugs. So the first line psychotherapy for anxiety disorder is usually cognitive behavioral therapy. And there is a Cochrane review that found that 46% of elderly patients with anxiety experience symptom relief or remission compared to 14% of controls. So I think that's pretty robust. Similarly, there's a randomized control trial of cognitive behavioral therapy in a primary care setting. And in that study, 70 patients were randomized to 10 sessions of cognitive behavioral therapy over 12 weeks, and 64 patients were randomized to usual care. And that usual care, what they did was they had bi-weekly supportive telephone calls for 15 minutes for 3 months. So in that study, 40% responded to the cognitive behavioral therapy and only 22% responded to the usual care. So that, I think that also shows a lot of support for the use of cognitive behavioral therapy. One caveat to that last study I mentioned was that we don't know for sure that it was a cognitive behavioral therapy that was what helped these patients, what helped them with their anxiety, because the ones that got CBT actually got more personal interaction because the CBT sessions were 45 minutes and they were weekly, and the usual care was just bi-weekly and it was 15 minutes. So, it might have been just that. Some other caveats for when you use psychotherapy in older adults is that just like with medications, unfortunately, the therapeutic response may be lower in older adults than it is in comparison to younger adults. A bunch of studies show that for whatever reason. Elderly patients are also more likely to drop out of cognitive behavioral therapy and other psychotherapy studies. There are some adjustments to therapy that are thought to be helpful for the elderly specifically. Some of them are that to have a very consistent structure, that if they get homework, that there are reminders to complete the homework, that you frequently summarize what you've been talking about, you use very concrete examples, and you use multiple learning modalities like written materials, tape materials, video materials to help consolidate the learning. All right, so I thought I would also mention some more like second and third line treatments for anxiety that I sometimes use or that others, psychiatrists may use. So one of them is Tai Chi. And Tai Chi, as we know, it's a East Asian, martial art, I guess, or type of movement that has been shown to be actually effective in reducing falls and also reducing the fear of falling in older adults. So it enhances the patient's confidence in their balance. So that's a very great thing. The disadvantage is that it can be time consuming, like the patient actually has to spend some time devoted to the study of this. So, and some people don't want to do that. So that's, it also may not be very available in every community. Another sort of third line, fourth line treatment that is D-cycloserine. D-cycloserine is specifically used for specific phobias. So the best treatment for specific phobia that we're aware of is exposure therapy, where the patient is exposed to what they're scared of little by little with the therapist over time. So D-cycloserine is actually an MDA partial agonist that is prescribed off-label to augment exposure therapy. And it is actually thought to reduce the sort of fear in the moment when they're going through the exposure treatment. And it sort of helps them to actually learn that it is no longer something to be feared. There are very small studies using this treatment. So I don't know how it would do in sort of a more robust, larger study, but the small studies are promising. So that's one potential treatment that could be used. Tricyclic antidepressants. They are effective for anxiety and depression. There's definitely studies to support their use. However, their disadvantage is that they have a lot of side effects like anticholinergic symptoms, weight gain, sedation, and they could definitely be lethal in an overdose scenario. Another treatment is pregabalin. I would also put into that category gabapentin. Pregabalin and gabapentin are both anticonvulsants that can be effective in generalized anxiety disorder. Basically, they bind to the voltage-gated calcium channel and they reduce synaptic release of several neurotransmitters. And so I do use gabapentin a lot in this to help if an SSRI or SNRI is not sufficiently effective. Pregabalin is not used as much in the US, but it is used a lot in Europe. I think why it isn't used so much here is that it's a controlled substance. But if the patient, it is used a lot here for chronic pain issues. So just be aware that can also help with anxiety. One of the disadvantages other than it's a controlled substance is that there's few replication studies to show that it's effective. And then lamotrigine is another anticonvulsant that I sometimes use as a third or fourth line treatment for anxiety. It has been shown to diminish panic symptoms. Again, there aren't a lot of studies to support its use. And then we already talked about benzodiazepines, which are rapidly effective. That's like their biggest advantage. And their disadvantage is all the side effects, dependency, falls, memory impairment, etc. Okay. So I spent some time talking about like medications, about psychotherapy, but there are just like other techniques that you also want to talk to your patient, like lifestyle changes that can be helpful in the treatment of anxiety. So things that can be helpful are just like talking with family or friends or someone you trust, a spiritual leader. A lot of elderly patients might not be open to like cognitive behavioral therapy, but they may be open to talking to like a spiritual leader or something, and that can be helpful. Stress management techniques like meditation and prayer can be very helpful. Exercise is helpful. And again, avoiding aggravating factors. So things like caffeine, nicotine, overeating, alcohol. So these are all things that a lot of patients will use to help them with anxiety in the short term, but you really have to talk about, how it might hurt them in the long term, and it actually can increase their anxiety over time. So that is important to talk about with the patients. And then, like over the last 2 to 5 years, I would say, like I talk a lot to my patients about limiting news consumption. Like a lot of my patients just get very anxious watching, Fox News or CNN or whatever it is that they're watching because it's a lot of doom and gloom. It's understandable. It is stressful. But so what I talk about with these patients is like making sure that it's limited to a certain amount of time per day or just like once a week or something like that. And that can be helpful as well. So that's all I've got. Does anyone have any questions?
Yeah, how about medical marijuana? Any role for that?
Yeah. So medical marijuana, like, yeah, a lot of my patients have a lot of questions about that. I also have questions. I don't, I mean, there are small studies to support its use. It's hard to complete these studies because they, federally it's illegal. So there just aren't like good, robust studies about the use of medical marijuana. And that's what I tell my patients. I also work for the VA, so I can't even prescribe it, but because it's a federal facility, but I tell them like I don't have any data to recommend or not recommend it at this point. Any other questions? Okay. Thank you, everybody. I hope you all have a good day. Good holiday.